So that we see your computer screen now. It's check in Zoom. دكتور اعتزاز. دكتور اعتزاز, can you hear me? Okay, I think it's already time. Dr. Majid, head of our neurosurgical Yemen Neurosurgical Society, will be chairman of this session. So, Dr. Majid, please, you can start.
Thank you very much. I'd like to thank you
ممكن نبدأ.
and to thank all of our colleagues who are attending us in this comprehensive neuroanatomy educational program, Module 3, Webinar 3. In the weekly webinar organized by the Yemen Neurosurgical Society and the collaboration of the WFNS Young Neurosurgical Forum with the Pakistani Society of Neurosurgeons and the Neurosurgery Coach and Neurosurgical TV. Today, Dr. Adel, he will be moderate the session, which will be introduced by Dr. Ihtijaj Ahmed, the assistant professor in the Bilal Medical College of Liquid Medical University. He will talk about the anatomy of the brain stem cells and the divisions, midbrain, bones, and medulla. And Dr. Abira Tariq, fellow surgical neuro-oncologist, FCPS Neurosurgery, Lahore Shaukat Kanun Cancer Hospital. We will talk about the vascular supply of the cerebellum and brain stem, arterial and venous anatomy. If they are ready to start, Dr. Ahmed, they can start the first lecture, please. Dr. Ahmed, Dr. Adel Qurebi is joining us or not?
Dr. Adel?
Yes, you hear me?
I think...
Yes,
Dr. Adel, you can start introduce our speakers.
Yes, hello everyone in Neurosurgical Society, Yemen Neurosurgical Society modules, number 3 in anatomy application. I welcome for everyone now. We start with Assistant Professor Ihtijaj Ahmed with lecture of anatomy of brainstem surface and divisions, midbrain, bones, and medulla. Hello, Dr. Ihtijaj. Can you start, please?
Assalamu alaikum. Am I audible, Dr. Adil, right now?
Yes, we can see.
Yes.
We can hear you.
Can you all people can see the screen right now? It's okay?
yes, okay. It's okay.
We'll see.
Yes, it's perfect.
Okay, thank you. Sorry for inconvenience because there was some problem in the screen sharing. I'm very thankful to Society of Yemen Neurosurgeon and PSN that who gave a chance to have a talk on such a very critical topic. Just we will discuss the anatomy of brainstem, some deviants, and a little bit a brief introduction of safe endosomes in the corridors to the brainstem. There is a saying that size not, but capabilities matters. That we can see a huge and big stone that is being thrown by a very small child. It's very true regarding the brain stem when we see the brain as a whole. The brain stem is just about 2 to 3% of the whole brain, and it's about 25 centimeter cube of whole volume. So it's being that we can see that it's so tiny and so small, but it is so capable that is controlling a lot of functions. And on the brain stem, a lot of I can say that the whole life is dependent on the brain stem. That's why then when the death is being declared, uh, often and very soon and early we see the brain stem reflexes. We can see in the picture that it's so small when we see the whole volume of the brain, but this small area, it is doing a lot of work. So these are some general features. It is about only 2 to 3% of the total brain volume. It's just a 7.5 centimeter total length. You can say that it is about only a index finger length of the whole brain, 7.5 centimeter. Occupies the posterior cranial fossa. It has the good work that it connects the cerebral cortex to the spinal cord. These some general functions and very important that it serves as some passage between the cerebral cortex and spinal cord for the very important ascending and descending tracts. It contains some very important reflex centers to control our very important two systems, that is the cardiac and respiratory. And out of 12, the 10th cranial nerve nuclei, they are also present in the brain stem to regulate different functions. So the brain stem is being divided into three main parts. We can see here the lower one, it is the medulla oblongata and the pons and midbrain. It has the connection lower part with the spinal cord, and upper part, the midbrain, is through the cortex or the forebrain for regulating different functions. Step by step, we will discuss the gross and detailed anatomy at each and every part. When we see the medulla oblongata, that is the lower part, from the cerebrovertebral junction is there, and the foramen magnum. It starts from there and it ends at the pontomedullary junction. That is the area. And below it is continuous with the spinal cord, and above it has the connection with the pons. And when we see, there are two main surfaces of the medulla oblongata. One is the anterior surface, or we call it the ventral one, and second is the dorsal face surface. We can say the superior aspect of the medulla oblongata. This picture shows the ventral aspect of the or anterior aspect of the medulla oblongata. And we can see in the anterior aspect a very midline structure or fissure or sulcus, we can say, that is called the anterior median sulcus or fissure. That is continuous downward below with the spinal cord as such as the anterior spinal sulcus, we call it. Same like that. On with this sulcus is very important. Surgical point of view, we will later discuss that how this sulcus helps us to enter into the medulla oblongata. So on either side of this sulcus is two elevations that is called the pyramids. These pyramids down goingward at the just above to the spinal cord, or the below side of the medulla oblongata, the decussate. This pyramid is nothing, just is that these are the corticospinal fibers that come from the forebrain or the cortex. They come here and then decussate and contralaterally the down goward. On the either side, on the anterolaterally to these pyramids, another elevation is there that is called olive. That's because of the olivary nucleus is there. In between these two, this the pyramid and the olive, we can see a sulcus here. That is the medullo-olivary sulcus. Yes.
Dr. Atijaz, sorry to interrupt, but we cannot see your cursor, your mouse. We cannot see it.
Sorry.
We cannot see your. You cannot see your pointer.
Can you see the mouse, the arrow? No.
I can't see.
No, we cannot see.
Right now. I think.
Nothing up to now.
you can try to exit screen sharing and then share again and see if it will work. We see the screen, but we don't see the arrow of your mouse.
Can you see now, please?
No, we cannot see the arrow. Please exit screen sharing now and then share again, and we see if it will work. Can you try to exit the screen sharing, doctor?
Yes, I'm trying.
And then, okay, I will stop from my side, and then you can share again and see. Okay. Okay. Please now try share again. Okay. We see your screen, but still we don't see your mouse.
So is it okay right now?
We see the screen, but we don't see the arrow.
So it's not working properly, I think.
Okay. Now you can continue like that, and we see. Dr. Ahmad, do you have any idea how to solve this problem? Mr. Ahmad?
I think I am not.
What?
I'm not able to get
So,
this
okay, no
arrow
problem.
because it
We
has.
you can go on and you just describe, and we will see.
Now it's okay, no?
No, we don't see the arrow set. But ask Ahmad, maybe he has some.
So sorry, because it is not working from my side, I think so. We are talking about the ventral surface of the medulla oblongata, just lateral to this pyramid. There is a sulcus, that is the pontoolivary sulcus. On the lateral side, this is the second elevation. This is the second one above. In between these two, this sulcus, it is very important because the hypoglossal nerve that originates from this sulcus, and from lateral to this one, just lateral and the posterior to olive, there is a middle cerebral peduncle that has been dissected. Oh, sorry, inferior cerebral peduncle. Between this olive and inferior cerebral peduncle, three remaining nerves, because the medulla oblongata, it originates the four lower cranial nerves, the ninth glossopharyngeal vagus nerve, and the cranial part of the accessory nerve. So this is the ventral surface of the medulla oblongata. And above one, when we see the pons in between these two, is the ponto medullary sulcus. It is very important regarding some structures of the that originate from the pons. When we see the dorsal surface, you can say the posterior surface or the medulla oblongata, the superior part of the posterior surface of medulla oblongata, it forms actually the floor of the fourth ventricle. That is very important. This is the floor of the fourth ventricle. The lower part is formed by the superior half of the medulla oblongata, and superior part of the floor of the fourth ventricle is formed the lower half of the, you can say, the posterior surface of the pons. So when we see this the conical structure in this one, again there's a midline fissure that we call it the posterior median sulcus. This same sulcus continues below with the spinal cord as the posterior median sulcus of the spinal cord. We can say that's why we can say, as the spinal cord is the continuation of the medulla oblongata, so little bit it's some mirror image of the medulla oblongata. On either side of these two, this one, the median sulcus, posterior median sulcus, again there's elevation and the bulging is there. That is called the tuber gracilis. And on the lateral of this one, tubercle gracilis, there is again one, there is a tubercle cuneate. In between these two, these are the sulcus. Underlying these structures, in underlying of the tubercle cuneate and the gracilis, there is the nucleus gracilis and the nucleus tubercle cuneate. That goes for the tracts to the posterior column of the spinal cord. So when we see above structures in the floor of the fourth ventricle, it gives some triangle. In the below one, we can see this is the hypoglossal triangle, and above and the below one, this is the vagal triangle, and then superior on the either side. These are the above to the triangle, above to the vagal triangle. These both side on either side bilaterally, these are the vestibule triangle. These are the structures. It's the same, the cadaveric view of the posterior surface or the dorsal surface of medulla oblongata. It shows some same structures. So after the medulla oblongata, when we see the pons is the some anterior and same surface of the posterolateral. The pons is on the either side and anteriorly on the ventrally. It is some convex area, the huge convex area. This anterior surface is whole. It is traverses by the transverse fibers, the pons on the anterior side, and these transverse fibers on the lateral side, anterolateral side, we can see the bulging. This bulging is there. These transverse fibers converge on the both lateral side, and they form again a second connection with the cerebellum, that we call it middle cerebellar peduncle. So middle cerebellar peduncle, nothing is just because the connection and some tracts which goes through from the pons to the cerebellum for different functions in the motor functions. So on the lower side of this one, that is the pontomedullary sulcus is there. That is very important sulcus. On this one, this is the foramen, that is called the foramen cecum. Just above the foramen cecum in the midline, this is the groove, and that groove is for the basilar artery, the very important structure. On above side, that goes to the midbrain. We will see later on the midbrain that where it resides. This pontomedullary sulcus, we call it. It is again an important structure because the four cranial nerves, three cranial nerves, they arise from here. From medial to lateral, we can see this is the abducent nerve, and then 7th-8th complex, 7 and 6 complex, this one, abducent, and then laterally 7th-8th complex. On the middle side of the pons, on the anterolaterally, we can see the fifth nerve originate from here. It has two parts. One is the motor and sensory. The smaller one which shows here is the motor, and the large one the pons. Above, on the upper side, the pons is connected with the midbrain, with the sulcus between the pons and the midbrain. This is the dorsal surface, or we can say the superior surface of the, again, the pons. It forms the superior part of the fourth ventricle floor. Again, it has some median sulcus is there on either side of this median sulcus. There are some elevations that is called the medial eminence. This is called the medial eminence. These both on the medial eminence, and the both side on the lower side of the medial eminence at the lower part. This is the vestibular area that we called, and again that is the billowish area that is called the substantia nigra. And so this is the midbrain, and midbrain again, it has some ventral surface. It is the ventral surface of the midbrain. We can appreciate some very important structures when you see the gross anatomy of the midbrain. This is the crus cerebri of the midbrain, and this is the sulcus in between the midbrain and the pons. Above to this one, this is the fossa, that the depression. That is very important fossa. Later on, we can see the structures inside it. That is the interpeduncular fossa. It has some important structures, and intraoperatively we can see that what is the landmark of this one. And superiorly, one can see the here on the above side, this is the tuber cinerarium, and in the below this one, lower side, these are the mammillary bodies. These two. Midbrain hold the brain stem. At the lower side, it has the extension till the spinal cord, and the superior side, it has the extension till the optic apparatus. We can appreciate the optic chiasm as well here. Till the optic chiasm, it is the area of the brain stem, and especially the midbrain. This is the same picture. This is the tuber cinerarium. These are the mammillary bodies. I will go into the dorsal surface of this one. This is the dorsal surface of midbrain. That is very important and contains very important structures. So superiorly, we can see here the third ventricle, and we can see the four bulgings on the lateral side, two above and two below. The superior two, these are the superior colliculus, and below one, these are the inferior colliculus, and this is the pineal gland. So these superior colliculus, when we see laterally, this has some bandage-like structure that is called the brachium. And this brachium, they connect the superior collex to the lateral geniculate body. This is the lateral geniculate body laterally for the visual apparatus, optic radiations. And this inferior colliculus, again, this has the brachium. This is the bandage-like structure, fibrous structure that connect with the medial geniculate body for the auditory areas. Below this one, we can see this on the lateral surface. These two thread-like structures are going. This is actually the fourth nerve, that is called the trochlear nerve. So this is the only nerve, trochlear nerve, in the brain stem that originate or arise from the dorsal surface. Most of the all nerves, they originate and rise from the anterior or anterolateral surface, but this has the origin from the dorsal surface of the midbrain. This is the same picture. So this is the endoscopic view, and we can appreciate the midbrain interior anatomy and the floor. You can see the pineal, the pituitary bilateral, superior colliculus, inferior colliculus, and this is the fourth nerve, the trochlear nerve. We can appreciate. So this is the brief introduction of the anatomy of brainstem little bit. When we talk about the surgical safe corridors, to me, I divide the surgical corridors into three main surgical corridors. One, when we say that the surgical entry zones in the brainstem, when we are entering in the brainstem, what is the surgical corridors could be? And second, when the surgical corridors to the brainstem, when we are approaching the brainstem, like the pathologies that is not intrinsic or not the diffuse infiltrating just at the brainstem, what could be? And second, the approaches, the safe approaches that can lead to the corridors. Most of the time, the brainstem most likely it has the gliomas, that is the infiltrating type. Most of the gliomas, they are infiltrating, that as the diffuse type, that is the very go inside to the parenchyma. And second, the cavernomas are there. So when we go inside to the brainstem, enter to the brainstem, there is a very safe zones. It has shown here that it is denoted, and the literature says that we choose the sulcus area, sulcus of this one, not on either side. When we see the medulla oblongata, we know that there are two sulcus. One is the anterior one, that is the anterior median fissure, and one is the posterior one, that is called the posterior median fissure. And second is the when we see at the level of olive and the medulla, olive and the pons pyramid, that sulcus can be chosen to get entrance into the medulla oblongata. Otherwise, this is very dangerous to go inside into the medulla oblongata. Any side of the brainstem, we can say, like it could be the pons, it could be the uh, midbrain. Same likewise, the pons, we can see the median fissure, and some again there are different structures there, like we can go on the above just lateral side of this one, that is called the medial eminence. On the medial eminence, just laterally we can go inside, and the median fissure of the pons, and laterally. This is the midbrain. Midbrain has some different and a lot of approaches to enter in it, and some pathologies can be added to the midbrain. When we see here, this is the lateral sulcus, the medial sulcus of the crus cerebri. This could be the entry zone, the safe entry zone in between these to the medial side of both crus cerebri. And second, we can go endoscopically when we are going into the third ventricle. And second, superior colliculus and inferior colliculus. Below to the superior colliculus, inferior to the colliculus, it is shown that we can go to the we can approach the midbrain as well. Endoscopically, when we are going, I told that interpeduncular fossa, which is very important clinically and as a surgical corridor, because it contains some important structures like the third cranial nerve is there, like the basilar artery is there. When we are going endoscopically, to either we are doing the ETV or getting any biopsy. That's why when it's being going a little bit posterior, we can damage. We can enter into the interpeduncular fossa, and that can damage the oculomotor nerve and the basilar artery. This is some diagrammatic and pictorial expression of the different approaches and safe entry zones. Anterior mesencephalog, what I call it, the medial to the crus cerebri, and this is the median fissure. This is laterally the olivera zone that is in between these two, because it is divided up some functional tissues, or you can say the nuclei of the cranial nerve. That's why we can enter into it. This is another pictorial and diaphragmatic expression of this one that shows, this is the upper side. This shows the midbrain approaches. that above through this one is the superior colliculus approach. That number one, it shows the medial part of the crus cerebri, this sulcus, the medius sulcus. This one number showing it is the median sulcus of medial sulcus of the crus cerebri. Number two, it shows the superior colliculus, and number three, it shows the below to the inferior colliculus, just above the fourth nerve. And these are the approaches to the midbrain, the median sulcus. On either side of the medial eminence, that is called the sulcus limitans, and the vestibular area. And the below urban, the medulla oblongata, it has large sulcus areas, so we can go and enter into this one. So these are the safe entry zones to enter into the brain stem, but it is very critical to get anything from the brain stem because it is very some crucial structures and very important structures are there. So just we can take the biopsy. And second, when we talk about some approaches, so we know very well that how to go there. It could be the posterior approach, suboccipital midline, the lateral for lateral approach, and we can go the perisigmoid, the retrosigmoid approach, and we can go the endoscopically, or when we are going through the midbrain, we can also go through the superior cerebral infratentorial approach to get some biopsy at that site. These are some approaches we can choose, but we can enter through these entry zones up to me. So this is the brief introduction and some entry zones to the brainstem. Thank you.
Thank you very much, Dr. Tizaz, about this lecture. Amazing lecture. If there is questions from the other colleagues, can you share? Under this also Dr. Ariba Tarek, the second lecture about the vascular supply of the cerebellum and brainstem arterial and veins anatomy. Please, Dr. Ariba, can you start, please?
Yes, sure. Okay. Is my screen visible to everyone?
Yes.
Okay. Assalamu alaikum.
Salamullah.
My name is Dr. Ariba, and I'm going to touch vascular supply of the cerebellum and brainstem. This presentation is going to be divided into, we will start with quick surface anatomy review. I will move towards the arterial supply, then venous supply, and if time allows, I like to touch applied anatomy as well. I will keep it very basic and simple so that neurosurgery residents can also understand. Starting from the surface anatomy of cerebellum and brainstem, Dr. Tizaz has dealt with it in a good length, but I would like to add a few things. So basically the surface of, when we study posterior fossa anatomy, we divide the surface of cerebellum into three parts, three surfaces. This is the tentorial surface. Shown in picture B is suboccipital surface, and C is known as the petrosal surface. Now, how I usually feel is that whenever we are reading anatomy, we are studying anatomy, we should have a 3D view so that we can understand what's going on. So this is Sketchfab. Of course, I don't have copyrights for this, but it's free and it's to be used. So just for an idea, this is how the petrosal surface looks like. And once you move around, this is the lateral view of the cerebellum and the brainstem in the posterior fossa. This surface, the surface that is hidden beneath the tentorium, this is known as the tentorial surface. and the surface that is present covered by the occipital bone is known as the suboccipital surface. So the three surfaces of cerebellum are tentorial surface, suboccipital surface, and the petrosal surface. Now, why is this important? Because this will help us in understanding the arteries that are present and are supplying these parts. So just a very brief and simple review of the cerebellar surfaces, starting from the tentorial surface. So as you can see, the main fissure that is present on this surface is this primary fissure, also known as tentorial fissure. As the name suggests, it's nearby the tentorium, and it's divided the tentorial surface of the cerebellar hemisphere into an anterior part and a posterior part. Now this type, the labeling on the right side is basically the old anatomical nomenclature for cerebellum, which divides into many parts. But just for simplification, let's focus on this part, that the tentorial surface is divided by the help of tentorial fissure into an anterior part and a posterior part. And the part of vermis that is present are culmen, declive, and folium. Continuing on the suboccipital surface, the folium is there in the midline. Beneath it is tuber, pyramid, and the uvula, the lowermost part. Now, the main fissure that is present here on this surface is suboccipital fissure, as the name suggests, because it is suboccipital surface of the cerebellum, and it divides this cerebellum into a superior part and an inferior part. Now, on the petrosal surface, we can see that this fissure is very deep, and this fissure is known as petrous fissure. It's divided into a superior part and an inferior part, and again, we can see the brainstem, the pons, and the medulla over here. Now, moving towards the arterial supply of cerebellum and brainstem, the first part of our lecture. So a very simplified, brief review of how it starts. It starts from two vertebral arteries. So two vertebral arteries, they join together and they form the basilar artery. I hope you can see my cursor. And this basilar artery give rise to bilateral icas or anterior inferior cerebellar arteries, pontine arteries, superior cerebellar artery, and on the terminus it gives rise to posterior cerebral artery, which communicate with the posterior communicating artery to form the circle of Willis. This is the circle of Willis. This is a human brain, and we can see this is the basilar artery formed by two vertebral arteries, giving rise to icas and FCA. Pica, posterior inferior cerebellar artery, is a part of vertebral artery, as we are going to see further. This is just an overview. Now we are going to go through each artery one by one and in detail. Simplified view, and as we can see, this two vertebral arteries join together form the basilar artery. What surface is this? So we are viewing the ventral surface of the brainstem, and this is our anterior posterior view. This is the petrosal surface of the cerebellum. We can see our icas running through bilaterally, the picas and superior cerebral artery laterally. Moving forward, all of the cerebellum and the brainstem structures have been removed to show how it is related to different cranial nerves. We are going to go through this later one by one. So you should not get confused by this slide. This just shows that how many ways we can actually divide vertebral arteries into different segments. So at different ways of dividing it, it's very complex. There's no point in going through everything. One thing that I want to remind everyone, especially residents, is that when we read anatomy, there are a lot of variations. So what we read is basically what is present in 70 to 80% of the brains. But yes, there are variations. There are a lot of anatomical variations, so don't get frightened by that. Starting from the vertebral artery, very simple, 4 segments. The first 3 are extradural, and the 4th is the intradural segment. So where does V1 segment arise? It's known as preforaminal segment, and it arises from the subclavian artery within the triangle of the vertebral artery, which is basically a triangle formed by the longus colli muscle and the anterior scalene muscle, and the first part of subclavian artery. Once it arises, this V1 segment, it ascends up to the transverse foramina of C6, not C7, C6 vertebra, and then it becomes a V2 segment. It's also known as foraminal segment, and then it runs from this C6 vertebra foramen to C2. Then it exits the C2 transverse foramen. It heads laterally to reach the transverse foramen of the atlas, and now it's known as the V3 segment. This segment is known as V3 segment, also known as Atlantic segment. So we had preforaminal, we had foraminal, and now we have Atlantic segment. And this V3 segment, vertebral venous plexus and C1 nerve roots are located within the superior suboccipital triangle, this superior suboccipital triangle. The C1 nerve root, this is very closely related to it. This C1 nerve root passes beneath the artery and above the posterior arch of atlas, as we can see in this diagram. This is the vertebral artery, and we can see C1 nerve root. The posterior atlanto-occipital membrane may form a funnel-shaped dense ring around the vertebral artery just before its dural entry point, and this is a point where it becomes an intradural. This V3 segment gives rise to posterior meningeal artery, posterior spinal artery, and deep cervical branches. Now, the V4 segment is the intradural segment, or it's also known as intracranial segment. Now, there's a pre-olivary sulcus, as Dr. Aditya showed us in previous slides, that marks the limit between the lateral medullary and anterior medullary. These are the two segments of the V4 segment. You don't have to get confused. Medullary means medulla oblongata. So this is just going to define that vertebral artery is running anterior to and lateral to medulla now. The lateral medullary segment, it passes between the rootlets of C1 here and ascends forward anteriorly to the dentate ligament and spinal accessory nerve. So the anterior medullary segment, it courses in front of between the hypoglossal rootlets, 12 of 12. It crosses the pyramid and it joins the contralateral side vertebral artery to form the basilar artery. So simple, vertebral artery, 4 segments, 3 are extracranial, 1 is intradural. It's a very short summary that we know. V1, V2, V3 are extradural segments, V4 is intradural segment. Now, once the two vertebral arteries join, they make the basilar artery. Basilar artery runs on the surface of the pons and it gives rise to ICA, superior cerebellar artery, and later on it ends up making the circle of Willis by the help of PCS bilaterally. Now, moving forward to rest of the brainstem and cerebellar anatomy, the best way to actually study anatomy of post fossa and brainstem is to divide it into complexes, into 3. The number 3 is very common here. So we have 3 complexes, an upper complex, a middle complex, and a lower complex. Every complex has one artery, one part of the midbrain, one part of the brainstem, that it's going to supply, a part of the cerebellar surface that it's going to supply, one fissure, some vessels, cranial nerves, and a peduncle. So as we know, there are 3 major structures of brainstem present in the posterior fossa: a midbrain, a pons, and a medulla oblongata. There are 3 vessels that are present here: superior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery, pica. There are 3 surfaces of the cerebellum: the tentorial surface, the petrosal surface, and the suboccipital surface. There are 3 fissures. The fissure formed between the cerebellum and the midbrain is known as cerebello-mesencephalic fissure. The fissure formed between the cerebellum and pons is known as cerebello-pontine fissure. And the fissure formed between the cerebellum and medulla oblongata is known as cerebello-medullary fissure. Similarly, we have 3 cerebellar peduncles that joins the cerebellum to these parts of the brainstem. We have a superior cerebellar peduncle in continuation with the midbrain, a middle cerebellar peduncle in relationship to the pons, and an inferior cerebellar peduncle in relationship to medulla oblongata. And then the cranial nerves 3, 4, 5 are part of upper complex, 6, 7, 8 are part of middle complex, and cranial nerve 9, 10, 11, 12 are part of lower complex. So if we divide the anatomy into these 3 parts, it's very easy to understand, it's very easy to learn. So moving forward to one artery at a time, I will start with pica first because it's a little bit more difficult. So it's easier to understand first, then we will move forward to other arteries. So pica is the most complex. That's why we're reading it first. It's a tortuous and variable course, an area of supply of cerebellar arteries. It basically arises from the vertebral artery near the inferior olive and passes posteriorly around the medulla. At the anterolateral margin of the medulla, it passes rostral or caudal to the rootlets of the hypoglossal nerve because it's part of lower complex. And lower complex nerves are 9th, 10th, 11th, and 12th. So it passes between the rootlets of hypoglossal nerve. At the posterolateral margin of the medulla, it courses lateral to the or between the file of the glossopharyngeal, vagus, and accessory nerve. Now this is how a pica looks like. We can see it's closely related to cranial nerve 9th, 10th, 11th, and 12th. In this section, we can see that it is passing between the rootlets of cranial nerve 12 and later on between the rootlets of cranial nerve 9, 10, and 11. Now, after passing through the nerves, it basically courses around the cerebellar tonsils and enter the cerebellomedullary fissure. What is cerebellomedullary fissure? Is between the cerebellum and medulla oblongata, and it passes posterior to the lower half of the roof of the fourth ventricle. And once it enters the cerebellomedullary fissure, its branches are distributed to the vermis and hemisphere of the suboccipital surface. And mostly it bifurcates into a medial and lateral trunk. The medial trunk supplies the vermis and adjacent part of the hemisphere because these structures are lying medially, and lateral trunk is going to supply the cortical surface of the tonsil and hemisphere because it's going to lie laterally. So a better way of seeing pica is by the help of simple diagrammatic illustrations. Then we will move towards the cadaveric dissections. So this is the right pica, and this is the left. So as we can see, left after erosion from vertebral arteries, it makes very tortuous course. Now these tortuous course is basically dividing it into 5 segments. What are the 5 segments of the pica? The first turn it takes when it moves in front of the medulla oblongata is known as anterior medullary. This is a part where it has just crossed the rootlets of hypoglossal nerve. Once it crosses the rootlets of hypoglossal nerve, it becomes the lateral medullary because that's a part which is usually lying on the lateral side of the medulla oblongata. Here, cranial nerve 9th, 10th, and 11th are usually arising. So once it has crossed the limit of 9th, 10th, and 11th nerve origin, it is now known as segment 3 or tonsillomedullary segment. This is also known as caudal loop because if you look at the lateral image, it's making a loop downwards. Now this is something which is very important when we are looking at the venograms, sorry. And then it turns upward and make a cranial loop. This is known as tilo-velo-tonsillar. Now, as the name suggests, tonsillomedullary segment is going to be present near the medulla and tonsils. And similarly, the tilo-velo-tonsillar segment is going to be associated with the similar structures. Now, 5, it divides further into cortical segments. These cortical branches further divided into medial branches and lateral branches. Lateral branches supply the hemispheres and medial branches supply the vermis, because this is how the anatomy of brainstem and cerebellum is, that the vermis is present in the medial side or medially and hemispheres are present laterally. So simple images showing the 5 segments of the pica color coded. Now this green segment after erosion from vertebral artery, this colorful artery is pica. By the way, this is suboccipital surface, as I'm assuming everyone must have understood by now. So this green segment is known as V1 or the first segment of the pica. As we can see, once it crosses the hypoglossal nerve rootlets, it becomes the lateral medullary or this red segment of the pica. After crossing the 9th, 10th, and 11th nerve rootlets, it's become the tonsillomedullary segment because it is closely associated with this structure. This is known as tonsil. Sorry for the cursor. This is tonsil. And then it moves forward to become tilo-velo tonsillar segment and then the cortical branches. Now cortical branches are further divided into this medial segment which is supplying the vermian branches, and the hemispheric branches. These hemispheric branches can further be divided into anterior, middle, and lateral group. This was suboccipital surface, and this is basically on the petrosal surface, the same pica showing its loop. And a lateral view showing you the caudal loop and the cranial loop, which we usually see in venograms. This is important. Again, you can see anterior medullary segment, lateral medullary segment when it crosses the 9th, 10th, and 11th nerve. We have the caudal loop or tonsillomedullary segment. Then we have a cranial loop or tilo-velo-tonsillar segment, and then we have cortical branches or the 5th segment of pica. Seeing it on roton dissections. Now this is an oblique view. This is superior and this is inferior. As we can see, one of the middle cerebellar peduncle has been removed and inferior cerebellar peduncle has also been removed to show the loops of pica as it moves on the anterior and lateral surfaces of the medulla oblongata and moves forward to supply the cerebellar hemisphere. Again, a similar dissection, but this is a posterior anterior view, and we can see how pica is taking tortuous courses on both sides. On the right side, it's more tortuous as compared to the left side, and yes, it's supplying the suboccipital surface of the cerebellum. Similar dissection showing variations and association of cranial nerves. I hope we have a basic understanding of pica by now. Just a chart to remind that it's made up of 5 segments and how it is supplying the suboccipital surface of the cerebellum. Now, for just a short break, because what I feel like is when we are studying and seeing anatomy a lot, we just get a little frustrated. So it's my favorite quote from Ben Carson. It's my belief that God gives us all gifts, special abilities that we have the privilege of developing to help us serve Him and humanity. Moving forward to the third vessel, that is ICA. It's originate from the basilar artery, usually as a single trunk. After coursing near and sending branches to the nerve entering the acoustic meatus, we know by now that ICA is branch of the middle complex. And to choroid plexus protruding from the foramina flasca, it passes around the flocculus on the middle cerebellar peduncle to supply the lips of the cerebellopontine fissure and petrosal surface. I hope by now everyone knows what flocculus is, but just to revise to medical students and some neurosurgery residents who are present there, flocculus is a part of cerebellum that is present on the petrosal surface, and this is flocculus, as you can see. Okay. Moving back, and it supplies the commonly bifurcates near the facial vestibular cochlear nerve complex to form a rostral and caudal trunk. Now, this is an oblique view. Again, we are seeing the two vertebral arteries joining together to form the basilar artery, and we can see this ICA. This is arising as a common trunk, as a single trunk, and it is moving towards the middle complex. This is a cranial nerve 9, 10, 11, 12, which are associated with pica. Pica is basically present down there. Okay, and this is cranial nerve 8 and cranial nerve 7, the two cranial nerves that are commonly associated, very closely associated with the ICA. Okay, as we can see, after arising, it basically, this is pons and this is medulla. It runs between the pons and medulla, sometime on the surface of the pons, and then it makes a course. It moves or touches around the flocculus, and then it supplies the petrosal surface of the cerebellum, this surface, by dividing into different branches. Again, it also has 4 segments. Now, the best way of remembering arteries is that every artery is going to have some segments, and then it's going to supply a surface. Whenever it's going to supply some surface of cerebellum, it's going to divide into medial branches, which is going to supply some part of vermis, lateral branches, which is going to supply some part of cerebellum, and then lateral branches are further divided into anterior, middle, and posterior group, something like that. So that's an easy way of remembering. So ICA is divided into 4 segments. Again, anterior pontine, lateral pontine, because ICA is associated with pons. So the name of the segments are anterior pontine, which is present on the anterior surface of pons, lateral pontine, the part which is touching the lateral part of pons, flocculonodular, which is near the flocculus, and cortical, which is supplying the cortex. What cortex? Cerebellar cortex. Which part? Petrosal part. The ICA is divided into these 4 segments. As we can see, these are further dissections. This is basically a posterior anterior view of the skull base. All of the part of cerebellum and brainstem have been removed, and we are seeing just a magnified view of one part, one side. These are the 2 vertebral arteries joined together to form the basilar artery. We don't have an image over here, and we can see this vessel. This is ICA. How do we know this is ICA? Because this is closely associated with cranial nerve 7th and cranial nerve 8. Now, sometimes this ICA is further divided into 3 segments as well. What are these 3 segments? These 3 segments are associated with meatus, internal acoustic meatus. So the segment of the ICA that is running towards the meatus, because it's going to go towards the meatus, is going to loop around it, and then it's going to supply the surface of the cerebellum. This segment, which is running towards the meatus, is known as premeatal ICA segment. The part that is near the meatus is known as the meatal segment, and the part that is running away from it or moving back toward the cortical surface is known as postmeatal segment. This is another way of defining the artery. As we can see, it's closely associated with cranial nerve 7 and 8. Some few honorable mentions, some branches that are present with ICA, that if it gives rise to the recurrent perforating artery. What is recurrent perforating artery? As the name suggests, perforating artery is an artery that is going to supply brainstem. Okay? How is that? Because we are going to understand this a little bit later. So this recurrent perforating artery is an artery which arises from the meatal segment of ICA, but it runs back towards the brainstem. Now, brainstem is somewhere here. It's going to run back towards the brainstem to supply it. If you see it here, this is the premeatal segment. This is the premeatal segment. This is meatal segment, and this is the postmeatal segment. And this recurrent perforating artery usually travels around the nervus intermedius, 7th nerve, and it supplies the pons or the brainstem. Some further dissection, these are magnified view of middle complex. And as we can see, this is flocculus or flocculonodular lobe. We can see the cranium of 7th, 8 here, cranium of 9, 10 down below, and cranium of 7 is present next to cranium of 8. We can see the pica sometimes, which is looping upward, and the ica. Also, what we can see here is labyrinthine artery, which is also a branch of ica. As the name suggests, it supplies the inner ear. Now this is a drilled view of meatus. We have drilled the bone here. Only the dura can be seen. We can see cranium of 7 and 8 going inside the meatus. We can see ica, and we can see the branches. This is known as labyrinthine artery that is going inside, and the branch that is going backward to supply the pons is recurrent perforating artery. The dura has also been removed, and as we can see, the cranium of 7th, 8 go inside. This is premeatal segment, the meatal segment going inside, and the postmeatal segment, and labyrinthine artery usually running here. Now, the rostral trunk, it usually sends its branches laterally along the middle cerebellar peduncle, which is the peduncle, cerebellar peduncle of the middle fossa, middle complex, to the superior lip of the cerebellopontine fissure and adjoining part of the petrosal surface. Petrosal surface is the surface of the cerebellum that is supplied by the ica, and the caudal trunk supplying the inferior part of the petrosal surface, including a part of flocculus and choroid plexus, the structure that are present on the petrosal surface. Now, the ica gave rise to perforating arteries to brainstem, choroidal branches to patella choroidea, and choroid plexus. And the nerve-related arteries, including the labyrinthine artery, which we saw in previous slides, recurrent perforating artery, and subarcuate arteries. Now, moving forward to the SCA, the 4th artery. SCA basically arises in front of the midbrain, usually from the basilar artery near the apex, and it passes below the oculomotor nerve, but may infrequently arise from the proximal PCA as well, and may pass above the oculomotor nerve. It dips caudally and encircles the brainstem. So arises on the front of the midbrain and it comes back. So it dips caudally and encircles the brainstem near the pontomesencephalic junction. What is pontomesencephalic junction? The junction formed between the pons and midbrain, passing below the trochlear nerve and above the trigeminal nerve. Now, this is something very constant. Usually, SCA always passes above the trigeminal nerve. It may pass sometime above or below the trochlear nerve, but usually always it's above the trigeminal nerve. But however, there are a lot of variations in normal human anatomy. Its proximal portion courses medial to the free edge of the tentorium cerebelli, and its distal part passes below the tentorium, making it most rostral or the most superior of the infratentorial arteries. And after passing above the trigeminal nerve, it enters the cerebellomesencephalic fissure, the fissure between the cerebellum and the midbrain, where its branches make several sharp turns and loops, giving rise to pre-cerebellar arteries. Now, this passes deep to cerebellar white matter and dentate nucleus. Why is this important? Because SCA gives branches to dentate nucleus. However, the rest of the dentate nucleus is supplied by pica. On leaving the cerebellomesencephalic fissure, where its branches are again medial to tentorial edge, its branches pass posteriorly under the tentorial edge and are distributed over the tentorial surface of the cerebellum, the surface which is supplied by the SCA. It usually arises as a single trunk, but it may bifurcate into a rostral and dorsal trunk. So as we can see here, sometimes it arises as a single trunk, like on this side, but sometimes it arises as double trunks, like 2 trunks, a rostral trunk and a caudal trunk, a superior trunk and an inferior trunk. This is just a variation that can be present. So looking forward to, this is a lateral view of the brainstem and cerebellum. Now, a part of cerebellum has been cut through just to show you dentate nucleus. This is the pica. Usually it gives rise to branches which supply the dentate nucleus. But however, SCA, it makes its caudalous turns and it gives rise to this pre-cerebellar arteries in this cerebellomesencephalic fissure, which is going to supply this dentate nucleus. Another thing that is present over here is that SCA, when it terminates into cortical branches, it supplies this surface, tentorial surface of the cerebellum. So SCA is again divided into 4 segments. Just was ICA was divided into 4 segments. PICA was only one, it was divided into 5 segments. So the SCA is divided into 4 segments. Anterior pontomesencephalic. As the name suggests, it's going to rise. Where is going to lie? Anterior pontomesencephalic, in between the line fissure between the pons and midbrain. So anterior pontomesencephalic, lateral pontomesencephalic, and then cerebellomesencephalic, between the cerebellum and mesencephalon, the cerebellomesencephalic fissure. And then cortical branches. Cortical branches are going to supply the tentorial surface of the cerebellum. Now, these cortical branches are hemispheric branches, which are going to supply the cerebellar hemisphere, and Vermean branches. So the hemispheric branches, they usually basically arise from the rostral and caudal trunks, and they arise at the level of depths in the cerebellomesencephalic fissure. This is cerebellomesencephalic fissure. We can see the cortical branches arising from here. And the most common pattern is there are 3 groups of branches: lateral, intermediate, and medial, which supply the 3/3 of the tentorial surface: lateral surface, the middle part, and the medial part. And this is how it looks like. So this is the tentorial surface of the cerebellum, and as we can see, the hemispheric branches are lateral hemispheric, intermediate hemispheric, and medial hemispheric. And of course, this is Vermean branch, which is going to supply the vermis. What are these branches? Small branches. These are precerebellar branches, which arises from the cerebellomesencephalic fissure, and they supply the distented nucleus. Some further dissection showing variations how it can arise as a single trunk and bifurcate laterally, or it may arise as a main trunk and never bifurcate. So these are some variations, or it may arise at different points, but always it's like the oculomotor nerve and trochlear nerve are above the SCA, and the 5th nerve is below the SCA. Another magnified view showing the same orientation. This is an oblique view, by the way. We can see cranial nerve 3 oculomotor nerve, cranial nerve 4 trochlear, and as we can see, SCA is beneath both of them, but above the cranial nerve 5, like I previously told. Some variation showing SCA into rostral and caudal loop. And this is something which we are going to deal later, the vein which is associated with it.
Services. Do you want to use Samsung Music or Spotify?
So, sorry for the disturbance. So, a brief summary. Branches of basilar artery are basically 3 main branches: superior cerebellar artery, anterior cerebellar artery. PICA is not included here because PICA is a branch of vertebral artery, and they are perforating pontine artery which supply the pons, which arises from the basilar artery when it's running on the pons. So this was all for arterial anatomy, very basic, but something that easily residents can understand, and I hope some surgeons have revised their anatomy as well. Now moving forward to the next part, which is the venous anatomy of the brainstem and cerebellum. So an easy way to understand venous anatomy is to divide it into groups. Just like we divided arteries into 3 groups, we have divided veins into 4 groups. What are the 4 types of veins that are present in the posterior fossa? We have superficial veins, we have deep veins, we have veins of the brainstem, and bridging veins. So let's go through all of them one by one. So superficial veins are the veins which are present, of course, superficially. So they are going to be associated with some surface of cerebellum. Because there are 3 surfaces of cerebellum that we have read before: tentorial, suboccipital, and petrosal. So superficial veins are in 3 groups: tentorial group, suboccipital group, and petrosal group. Now the tentorial surface veins are basically Vermean veins and hemispheric veins, because we have read this before. The tentorial surface, if we roughly divide it, it's into 2 parts. The middle part is vermis, and the lateral part is the tentorial surface of the hemisphere of the cerebellum. The suboccipital surface consists of inferior Vermean veins, inferior hemispheric veins, just like it was the tentorial surface. However, we have 2 other veins here, like the retrotonsillar vein. Retro means behind, so it's behind the tonsil, and a medial and lateral tonsillar veins, because tonsils are present on the suboccipital surface. Now the petrosal surface is supplied by only one vein, which is anterior hemispheric vein. Easy. Now we're going to see illustrations of these. Moving forward to the deep group of veins. Now it is divided into 3 parts based on the 3 fissures. The 3 fissures that are present in the posterior fossa: cerebellomesencephalic between the cerebellum and midbrain, cerebellomedullary between the cerebellum and medulla oblongata, cerebellopontine between the cerebellum and pons. Now, the cerebellomesencephalic fissure will have a vein of a peduncle. Which peduncle is associated with cerebellomesencephalic fissure? Superior cerebellar peduncle. So the vein will be known as vein of superior cerebellar peduncle. It will also have a vein of cerebellomesencephalic fissure, the same name, and some pontotrigeminal vein and tactile vein. Cerebellomedullary fissure will have a vein of cerebellomedullary fissure and a vein of inferior cerebellar peduncle, because inferior cerebellar peduncle is associated with medulla. It will also have supratonsillar and choroidal veins. Cerebellopontine fissure will have vein of cerebellopontine fissure and vein of middle cerebellar peduncle, which is present here. Easy to remember up till now. Moving forward to veins of brainstem. Now, when we talk about veins of brainstem, we divide it into two types. One which are running longitudinally, as the name suggests, they are known as longitudinal veins. And the veins which are running transversely or dividing or communicating with the two longitudinal veins are known as transverse vein. So longitudinal veins which are running in midline are known as median anterior pontomesencephalic or median anterior medullary vein. As the name suggests, median anterior medullary vein is going to run on medulla anteriorly, and median anterior pontomesencephalic vein is going to run on pons and midvein anteriorly and in the middle. Now the anterolateral group of veins will be running laterally, anterolaterally. These are further lateral anterior pontomesencephalic vein, as the name suggests, running in the lateral anterior aspect of pons and midbrain, and lateral anterior medullary vein, which is going to run on the lateral anterior surface of the medulla. Laterally, we have lateral mesencephalic vein, lateral medullary, and retroalveolar veins. Very simple to remember. Just visualize the surfaces they are going to be associated with. Transverse name, they are a little bit difficult to understand, but let's go through them one and one. So peduncular vein associated with peduncles, posterior communicating vein, transverse pontine vein, transverse medullary vein, vein of pontomesencephalic sulcus, and vein of pontomedullary sulcus. In the last, there are also bridging veins. Now, bridging veins are the veins that bridge these veins of brainstem, superficial vein, and deep veins to the sinuses in which they are draining. So these are known as bridging veins. Bridging veins are divided into the groups in which they are draining, the sinuses in which they are draining. So the veins that drain into the vein of Galen are known as Galenic group. The veins that drain into trochlear hierophyllae or the confluence of sinus and tentorial sinuses are known as tentorial group. The veins that drain into petrosal sinuses, superior and inferior both, are known as petrosal group, and there are some other bridging veins which are the exceptions. So easy to understand by now. Now, before moving forward to the dissections of these veins, I will just touch a little bit about the venous sinuses. I hope everyone knows this by now, but just a quick revision. We have superior sagittal sinus, we have inferior sagittal sinus, we have the straight sinus, road transverse sinuses joined together at trochlear hierophyllae. These transverse sinus running and becoming the sigmoid sinus and draining into internal jugular veins. We have superior petrosal sinus and inferior petrosal sinus. Superior petrosal sinus draining into transverse and sigmoid junction, while inferior petrosal sinus draining into sigmoid sinuses. Also, we have these occipital sinus on the back and some other vein of Galen's in structure. Again, superior petrosal sinus, inferior petrosal sinus joining together, transverse sinus becoming the sigmoid sinus and draining. So, moving towards the superficial veins first. Superficial veins, as we learned a few minutes back, they drain the cortical surface of the cerebellum, and they are divided on the basis of which cortical surface they are going to drain. So they are divided into tentorial, petrosal, and suboccipital group. Now the tentorial surface is drained by superior hemispheric and superior Vermian vein, as we read before. The suboccipital surface is drained by inferior hemispheric, inferior Vermian vein, and the petrosal surface is drained by the anterior hemispheric veins. Now, this is the tentorial surface of the cerebellum. The tentorium has been cut on both sides so that we can see the cerebellum. We are viewing the brain from the above. It's a cut section at the level of midbrain. And we can see these vessels, the veins that are running. The ones on the surface are superior hemispheric veins. And the one in the midline, which is draining the vermis, is superior Vermian vein. Very simple. We can also see vein of cerebellomesencephalic fissure here, which is a deep vein. This is the suboccipital surface. Now the vein of the suboccipital surface is inferior hemispheric vein laterally and inferior Vermian vein medially. We can see these veins here. And this is petrosal surface of the cerebellum. The vein of the petrosal surface is anterior hemispheric vein, which we can see is running over here. Now this anti-hemispheric vein joined together with other veins, as we are going to see further, and will drain into superior petrosal vein. Now, this is a diagrammatic illustration of how these veins are draining. So basically, we have another way of dividing it, as we read before, is by the help of the drainage system in which they are draining. So the color coding here is that the green are the veins which are draining into the vein of Galen, so they are Galenic group. The one in blue are those that are draining into the petrosal sinus, so they are petrosal group. And the one that are here brown or red are the one that are draining into the tentorial sinuses, so they are known as the tentorial group. Again, similar thing, but we are looking at the cornal section, and we can see how veins that are near the tentorium are draining into the tentorial sinuses, and the veins that are near the petrosal sinus are draining into petrosal sinus. Now the deep veins, they are the veins that are running in the fissures between the cerebellum and parts of the brainstem. So the vein of the cerebellomesencephalic fissure arise in the cerebellomesencephalic fissure is intimately related to superior half of the roof of the fourth ventricle. The vein of cerebellomedullary fissure courses in the cerebellomedullary fissure. The vein of the cerebellopontine fissure courses in the cerebellopontine fissure and is basically related to the lateral recess and lateral wall of the fourth ventricle. And the deep tonsillar vein are also included in this group. This is again the similar dissection we saw a few minutes back, where we were at that time we were looking at the cortical veins, but we can also see the vein of cerebellomesencephalic fissure here. It will be associated with the vein of superior cerebellar peduncle, which will be present somewhere deep here. And as we can see, it's going to later on being draining into superior petrosal vein. This is a further dissection removing a part of the tentorial surface of the cerebellum to show that how the vein of superior cerebellar peduncle on both sides join together to form and drain into the vein of superior cerebellar mesencephalic fissure. These two are deep veins, and then it's going to join and drain into the superior petrosal vein. Now the vein of brainstem, as we discussed previously, they are divided into different types. On the basis of orientation, they can be longitudinal and transverse on the direction in which they are running. They can be divided on the basis of the brainstem part. They are draining like mesencephalon group, pontine group, medullary group, or they can be divided in the part surface of the brainstem. They are draining like median group, lateral anterior group, lateral group. So the longitudinally oriented veins, which is the most common way of dividing these veins, are the median anterior pontomesencephalic and the median anterior medullary vein, which courses in the midline. The lateral group again, anterolateral group, and then which is going to run on the anterolateral surface, and the lateral group which is going to run in the lateral fissure, which courses on the lateral surface of the brainstem. The transversely oriented veins running in the sulci at the junction of the pons and mesencephalon and the pons and medulla are the veins of pontomesencephalic and pontomedullary sulcus respectively. The transverse pontine, as the name suggests, running transversely on the pons, and transverse medullary vein running transversely on the medulla oblongata. They run across the anterior lateral surface of the pons and medulla. A simple diagrammatic view of the veins of the brainstem. Now, these veins which are running longitudinally, these are longitudinal veins. The one in the center are anterior. The one on the anterior lateral sulcus are anterolateral. The one on the lateral side are lateral. So again, this will be because it's associated with pons and mesencephalon. What will this vein be? This is lateral. So this is lateral pontomesencephalic. This will be lateral medullary. This will be anterior pontomesencephalic, anterior medullary vein. And these are the transverse vein, the joining veins. This will be transverse pontine because it's transverse and it's present on the pons, transverse pontine vein. Similarly, transverse medullary vein because it's running on the medulla and it's transverse. So it's that easy to understand. Now looking at these veins of the brainstem on an actual brain, how they look like. Longitudinal groups, not something to be afraid of. This is going to be the anterior group, then anterolateral veins and the lateral veins. And then the ones that are running transversely are transverse vein. Because this is on pons, this will be the transverse pontine vein. This will also be the transverse pontine vein. These will be transverse medullary vein because they're running transversely and they're on the medulla. Similar images showing similar thing. So now, up till now, I am pretty sure that we have touched a lot of arterial anatomy and venous anatomy. So how do we apply it? Why is this important? This is a very simple chart of what occlusion of simple artery can lead to. Very basic, something we read in med school, that if then ICA or supracerebellar artery infarct is present, if this is occluded, what will happen? Because it's supplying superior part of cerebellum and posterior lateral midbrain, the patient will have symptoms of ataxia, dysarthria, nystagmus, nausea, vomiting, headache, vertigo. If ICA is involved, what will happen? Because it's supplying the petrosal surface of the cerebellum and pons, inner ear structure, we will have vertigo, nausea, vomiting, Horner syndrome, unilateral hearing loss, stuff like that, and ataxia. What will happen if pica is blocked? Now we will have headache, horizontal, ipsilateral nystagmus. Another thing which I wanted to include, I know there's a lot of description that can go into this, and we can do this like another section, another lecture. But why is learning anatomy important? Because sometimes you have to look at these angiograms and then you are unable to understand what is what and which artery is which artery. So this is what this is, an angiogram. This is a arterial view, arterial face, and a Waters projection. Because it's perpendicular to clavis. What is these? These are the both vertebral arteries. They are joining together to form the basilar artery. I wanted this to be some interactive kind of session, but I think mics are turned off from audience. So both vertebral arteries joining together to form the basilar artery. What are these arteries? These are picas arising from the vertebral arteries. What are these two paired arteries arising from the basilar artery? These are ICA running laterally. And then this is SCA, superior cerebellar artery. And before it terminates, basilar artery terminates into two posterior cerebellar artery labeled by 7. See, very easy to understand once you have gone through the anatomy. Similarly, why were we so concerned about the segments of the pica? Because of the venogram. Now we can see this is a Waters projection and this is a lateral projection. What we can see, this is a delayed phase, so we can see sinuses over here. This is superior, this is sigmoid sinus. We can see superior petrosal sinus. We can see part of inferior petrosal sinus somewhere here. See, and what else we can see? The veins of the brainstem here, sinuses. So that is why it's important to learn this anatomy. I hope I have not bored anyone yet, and I'm open to questions now. Thank you for your patience.
Thank you, Dr. Ariba. It's a great lecture about vascular anatomy of the cerebellum and the brainstem. Thank you, Dr. Tizaz, about the previous lecture. Now, if you have Dr. Magid Aimer, Prof. Dr. Magid Aimer, if you have anything to say, can you please? Dr. Magid, you hear us?
I'd like
You hear me?
to also to thank Dr. Atijad and Dr. Ariba for these very precise and very full lectures. And I'd like to thank to the audience who joined us and share in the presentation of these lectures, part of the educational program of the neuroanatomy. And I hope to continue in the program in the next sessions with the audience, and I'd like to thank Dr. Adil for sharing us. Thank you for everybody, and thank you very much.
Thank you.
Thank you very much. Thank you very much, Dr. Ariba Tariq, for this comprehensive presentation and very nice slides. And also thank you very much, Dr. Atizaz, for your presentation. Dr. Adil, you can see if there is anyone have any questions from the audience, either in the chat or if you have any comments or any points to add.
No questions in the chat. Only congratulations for this lectures. Beautiful described only this who see about the participate. Who say about from the participate. Thank you.
I think by this, if there's no more questions.
Clear clear cultures,
everyone.
lectures about clear lectures about the anatomy this day. Clear.
Yes, the lecture was very comprehensive and very beautiful and very precise with a lot of information. And I think everyone will have good knowledge today and very good information today. So I wish if there is no more questions, Dr. Majid, you can conclude the session if you don't have any more questions.
As long as there's no more questions, I'd like to again thank everybody who joined us and who shared us in these lectures, and we hope to continue the program on the same level, inshallah. Thank you very much for everybody. Thank you.
Thank you, everyone, and see you all, inshallah, next Friday. Thank you,
Thank
Dr.
you.
Ariba, and thank you, Dr. Atiyas.
Thank you for all.